The American Brain Tumor Association is pleased to welcome you to our patient and family meeting 3-day series, Brain Metastases, Life After Diagnosis. My name is Emily Lippert, Senior Program Manager here at the ABTA. This 3-day meeting series will focus on life after a brain metastases diagnosis and the whirlwind of changes and emotions that take place while already managing a primary cancer. Attendees will gain insight into how you can increase your quality of life and manage the cognitive and emotional changes. We invite you to attend all 3 days of the meeting. Today's meeting is all about symptoms and treatment side effects. Tomorrow, we will cover how brain tumor treatments affect your brain and keeping your brain fit. And Thursday, day 3, we will cover the emotional journey of brain metastases. As a leader of brain tumor education, support services, and research, the ABTA created the Metastatic Brain Tumor Collaborative to inform, support, and empower patients diagnosed with a metastatic brain tumor. Thank you to all of our collaborators for their partnership of this meeting series. Additionally, thank you to ABTA sponsor Accuray for their support of this meeting. And now, without further ado, let's begin day 1 of our brain metastases meeting, symptoms and treatment side effects. Why am I experiencing these issues? Cancer spreading to the brain may result in symptoms and side effects depending upon where the brain metastases is located, the size, the number of brain mets, and treatment. Attendees will understand how symptoms vary from person to person. Our speaker today is Dr. Ayal Aizer, who is an associate professor at Harvard Medical School and the disease site leader within central nervous system radiation oncology, with a particular focus on brain metastases at Dana-Farber Cancer Institute, Brigham and Women's Hospital. Dr. Aizer leads multiple clinical trials and other clinical research efforts focused on brain metastases. Thank you for joining us, Dr. Aizer. You may now begin your presentation.
Thank you so much, Emily, for the lovely introduction, and just wanted to thank the entire team at the ABTA, including Emily and Nicole and Breen and Mindy, and so many others who helped me put these slides together and who organized this wonderful week. It's a real honor to speak in front of you today, and I'm looking forward to a nice dialogue at the end of the presentation as well. So I'll share a screen and So we're going to be talking today about brain metastases. And as Emily mentioned, we're going to be focusing on signs, symptoms, and management of this condition. These are my disclosures. And the objectives are to focus on the treatment of brain metastases, to talk a little bit about what makes a brain metastasis different than the primary cancer type that it comes from, to talk about how symptoms vary from person to person, and to really focus on how the size, location, and number of brain metastases determines the symptoms, side effects, and management that patients experience. So at a very basic level, what is a brain metastasis? So a brain metastasis is where a tumor that started outside of the brain spreads, usually through the bloodstream, into the brain. And what happens is these tumor cells get stuck in the smallest of blood vessels called capillaries, and they can often grow and push on the brain from there. So in this cartoon, you see these tumor cells traveling up through the blood vessels into the brain and growing from there. What makes the brain different than, let's say, the liver or the lung or the bone or these other sites that cancer can spread to is this notion of the blood-brain barrier. And the blood-brain barrier is not an absolute entity, it's more of a relative one, but what it really is getting at is that it's hard for many things to get into the brain, like drugs, chemotherapy, immunotherapy, targeted therapy. It's a part of the body that keeps itself healthy and regulated through these blood vessels that are lined with cells that have junctions on them that don't let many things through. And as a result, when you try to get drugs or therapies into the brain, it's often harder. So the management of the brain is often different than the management of the rest of the body. This is an example of a brain metastasis. We use MRIs predominantly to image the brain. So most of the time in the rest of the body, we're looking at things like CAT scans or PET scans or bone scans. But for the brain, the best test is almost always the MRI. So this is an example of an MRI. And these are a couple of different sequences from that MRI. In this case, on the left sequence, you can see a brain metastasis in the frontal lobe. And that brain metastasis is causing some swelling, which we sometimes call edema, on the image on the right. So this cloud-like structure is swelling caused by the brain metastasis. And unlike in many primary brain tumors, this swelling doesn't have tumor cells mixed in. It's just swelling. And that makes the management a little bit different in terms of how we design radiation fields, for example, when it comes to metastases versus primary brain tumors that start in the brain. It's important to recognize that not everything that is abnormal on an MRI of the brain in a patient with cancer is a brain metastasis. One of the things we spend a lot of time thinking about is what are the other possibilities that this abnormality could be. For example, on this scan, there's an abnormality here in the frontal lobe. And the things that we're wondering when we see a scan like this, especially because we're not typically doing a biopsy to confirm because it's a brain biopsy, is this a brain metastasis? Could this be another type of tumor that started in the brain? Could this be something that isn't a tumor at all? Could this be an infection, an inflammatory focus, a stroke, or a blood vessel abnormality, among other things? When patients with brain metastases are discovered to have involvement of the brain, some patients have symptoms, others may not have symptoms. And a lot of the time, what depends on whether a patient has symptoms or not is whether that type of cancer that they have has screening of the brain involved in the guidelines for the management of that cancer. Because for some cancers, like we'll look at in a few slides, imaging of the brain is part of the screening protocol, no matter if there are symptoms or not. So they'll get imaging of the brain in the form of an MRI typically, just to look to see if tumors are there. And if they are there, they're typically identified before patients have any symptoms because they're getting a screening scan. For some other cancers, there is no screening. And when those patients present, they often have symptoms leading to a scan. And therefore, these patients can present quite differently. Symptoms that relate to brain metastases can be general in nature, meaning they're not specific to a part of the brain. That could include headache, that could include a seizure, or they could be focal, meaning they're located in a part of the brain, and the deficit that a patient might have relates to that specific function of the brain. People are often worried about seizures for very understandable reasons. Thankfully, seizures are more uncommon than they are common, but they do affect about 10% of our brain metastasis patients at the time of presentation. And if patients have not had a seizure at that time, thankfully only about 10 or 15% of them will ever develop one. So yes, it's definitely a concern, but most of our patients will never have a seizure, thankfully. So this is just a caricature of the anatomy of the brain. It's divided into several sections. Okay, we sometimes think of it as a supratentorial section, meaning the upper part of the brain, which is the area that's in the different colors here, and an infratentorial section, which is mainly composed of a structure called the cerebellum and the brainstem. And the brainstem is the extension of the spinal cord when it gets into the area of the skull. Okay, so when the spinal cord starts reaching the skull, then it sort of turns into the brainstem. Each part of the brain has a specific function, and the cerebellum is most involved with balance, coordination, and articulation of speech. The brainstem is a really important part of the brain. It involves a lot of facial function, and all of the pathways to the rest of the body run through the brainstem. And that makes sense because the brainstem really is basically the spinal cord once it gets high enough. So all of the pathways that allow you to move your arms or your legs, or to feel something in your fingers, or to walk, come ultimately through fibers that pass through the brainstem. In terms of the supratentorial lobes, the temporal lobe is mostly involved with speech and language. It has some memory function as well. The occipital lobe is largely focused on vision. The frontal lobes are mostly cognition and personality, but the very back of the frontal lobes does coordination of muscle strength. So they allow you to move the muscles of your body. And the parietal lobe is largely a sensory structure that focuses on higher order sensation, including where your arms and limbs are in space, higher order visual processing, and that sort of thing. This is a cartoon that we often learn about in medical school called the homunculus. It's sort of a cartoon that shows what each part of the body would look like if it was the size of the amount of the brain devoted to it. So as you can see, the areas of the body that are most supplied by the brain, meaning the most amount of brain tissue, is devoted to coordination and control and sensation of that structure would be the hand. You look at all of the cortex that's devoted to the hand, and the face. So these are areas that are represented very well when it comes to the motor cortex, for example. And there's a lot of tissue in the brain devoted to allow you to move your hands in the many ways that we can all move our hands. So here's a couple of examples of some symptoms that can develop related to the part of the brain where a lesion or tumor is located in. So this is anterograde amnesia. This means the inability to form new memories or difficulty with forming new memories. And this is a metastasis that was treated with radiation and then developed some radiation change. And it's located in an area called the hippocampus, which is very involved with memory function. This is an area where the cell bodies of a nerve that controls sensation to the face live. So this would cause a so-called right cranial nerve 5 palsy, or practically numbness of the right side of the face. We touched on seizures before. This is data that is population-based and also institutionally based that shows among patients who are not in the 10% who have a seizure at diagnosis, what percentage of them will develop seizures over time. So you see the proportion of seizures on the y-axis, time on the x-axis, and what you can see is that approximately 10 or 15% of patients will develop seizures at some point after their diagnosis. These are the cancer types that, per the NCCN, which publishes guidelines which many practitioners use to manage patients, and which many insurers use to determine what will be covered by insurance or not. These are the guidelines and how they present brain screening or lack thereof by cancer type. So for non-small cell lung cancer, small cell lung cancer, advanced melanoma, and some rarer other tumors, screening of the brain is recommended, meaning even in the absence of symptoms, we should do at least one brain scan and sometimes more to look to see if the brain is involved. Other cancers have no mandate for brain screening, and that includes breast cancer, renal or kidney cancer, other genitourinary cancers, head and neck cancer, gastrointestinal cancers, gynecologic cancer, including ovarian cancer, and prostate cancer. Some of these cancer entities and cancer types have some risk of developing brain metastases more than others. And one of those types is patients with metastatic breast cancer. And currently, there's no mandate for screening of the brain in that cancer type. So we are running a study at our institution looking at patients with metastatic breast cancer and performing up to 2 screening MRIs of the brain. And if metastases are identified, then we have a multidisciplinary discussion on management and we treat the patient accordingly. If both of those scans are negative, then no further MRIs are done as part of screening on this trial. And what's nice to see is that there's at least 2 other trials, one of which was recently published, looking at this exact question. So hopefully we'll get more data on these cancers where screening is not currently recommended, to determine whether screening should be done, and if so, in what specific patients should it be looked at, and how should we do the screening, at what time points. I'll take a small detour and talk briefly about leptomeningeal disease. For those who are not aware, leptomeningeal disease is where there are tumor cells that are no longer really forming solid, typically kind of circular tumors in the brain, but rather they're involving the inner lining of the brain and the fluid that bathes the brain and the spinal cord. So this is basically like the spinal fluid, the brain fluid, now has tumor cells in it, and that can be a situation that has to be sort of addressed differently. Patients with leptomeningeal disease tend to be more symptomatic than patients with intact brain metastases. They tend to have more headaches, more problems with their facial nerves, more problems with their cerebellum, which does balance, and their spinal cord, it can be more impacted. The diagnosis can be made with imaging or cytology. Cytology means doing a spinal tap and taking the fluid that's obtained and spinning it down and looking for tumor cells. Sometimes there can be false negatives on those spinal taps, so some people do more than one spinal tap to fully exclude the diagnosis if it's suspected. This is an example of what leptomeningeal disease looks like. So in the cerebellum, in this case on the top left, there are these bright white streaks that shouldn't be there. And these bright white streaks are little tumor cells in the inner lining of the brain that are taking up contrast. And you can see that in the bottom left image as well, higher up in the brain, little white streaks that represent tumor cells filling the grooves and folds of the brain. The cranial nerves are typically impacted in this condition. So this is cranial nerve 7 and 8. They control facial function in terms of strength. So facial strength, smiling, frowning, lifting your eyebrows up, closing your eyes real tight. And the 8th cranial nerve does hearing and balance. And those are the 2 nerves that, for whatever reason, are most commonly impacted in leptomeningeal disease. And here you can see some enhancement, meaning contrast uptake, along those nerves. How do we treat leptomeningeal disease? There's not a standard set pathway. It really depends on the nuances of the individual patient. The first thing that we ask ourselves is the pressure in the brain high? Because in leptomeningeal disease, people can get elevated pressure in the brain that sometimes requires treatment to alleviate, like a shunt, to shunt away some of that fluid and some of that pressure, so that patients don't get as many symptoms from that pressure. We sometimes use radiation, usually in the form of larger fields. So this isn't an entity that you can really do a lot of targeted radiation for. It needs to be like the entire brain or most of the spinal cord, or sometimes both the brain and the spinal cord, as we'll look at in a moment. There's chemotherapy that can be used for this, or other targeted therapies. Sometimes they can be taken orally or through the IV, just like normal drug therapy can be given. And sometimes it can be given intrathecally, which means that it's given directly into either the brain fluid or the spinal fluid, to really try to control those cells as best as possible. I'll just have one more slide on this because it's not the main focus of today's talk. But recently in the world of radiation, there was a nice randomized study that was published by Jonathan Yang, who examined patients with leptomeningeal disease, and mostly breast and lung cancer patients were randomized to receive either the entire brain and spinal cord being radiated with something called proton radiotherapy, or more limited fields using X-rays, okay, but not the full brain and spinal cord. And what they found was that the craniospinal radiation, radiation to the entire brain and the entire spinal cord, not only improved control rates, but actually was associated with better longer-term survival. So this was a very, very intriguing and compelling study. It was a phase 2 study, so it's now moved on to the phase 3 realm, where it's sort of being piloted to see if this is a trend that really holds true and really might change the standard of care more globally. It's already had an impact on standard of care, but a definitive phase 3 study would push that even further. So for most of the rest of this talk, we're going to focus on the management of intact brain metastases. So how do we treat brain metastases? And this is a topic that sometimes can be harder for many of our trainees to learn because it doesn't follow an algorithm or a recipe. It's not the same for everybody, nor should it be the same for everybody. Every patient with brain metastases is very different, much more than every patient with a typical cancer type is different. Because if you think about brain metastases, they come from different tumors. So a patient with breast cancer is different than a patient with melanoma, which is different than a patient with colorectal cancer. They could develop at different time points during a patient's clinical course. Some present right at diagnosis of cancer. Some present 2 years later. There can be very different burdens of cancer in the brain when it's discovered, and there can be very different burdens of cancer in the body at the time that the brain tumors are discovered. Patients can be different ages. They can have different abilities to tolerate therapy. So as a result, there's really not a one-size-fits-all management for brain metastases, and care, although it's based on literature, tends to be more individualized. And we really think critically about what makes the most sense for this particular patient. There are many options. Sometimes we just watch brain metastases. Like if they're discovered incidentally and they're really, really tiny, sometimes we'll just watch them for a little while and see if they grow, and if so, how quickly they grow before we intervene. Sometimes we'll use drug therapy alone to manage them, and there are better and better drugs, as we'll see, that are working in the environment of the brain, breaching that so-called blood-brain barrier more and more effectively. Sometimes patients need surgery. Sometimes patients need radiation. And there's a couple of different flavors of radiation that we'll look at. So let's touch on surgery. And I'm not a neurosurgeon, I'm a radiation oncologist, but I'll just talk at a basic level about how we think about surgery, as radiation oncologists. So when would we send a patient to a neurosurgeon to talk about the risks and benefits of surgery? So sometimes we send them if there's diagnostic uncertainty and surveillance isn't an option. So what does that mean? We see something in the brain, we don't know what it is, but it's big enough or bulky enough that we can't just say, we'll see you in a month with a new scan. We really need to sort of figure it out sooner than that. And sometimes that's a reason to either do a biopsy or consider surgery. If a patient has symptoms and we've tried steroids and the steroids are insufficient in controlling those symptoms, that can be a reason to send someone to surgery. If a patient has a bulky tumor, bulky doesn't have a strict definition, but more than 3, 4, 5 centimeters in size, that's usually a good reason to have a patient meet with a surgeon. And lastly, sometimes we see a patient who has like a single brain metastasis. And we think that if everything goes right with that one brain metastasis, because they have nothing else in the body or a very limited amount of disease in the body, we might be able to keep them alive long-term forever. And sometimes we think that surgery followed by radiation can help achieve that more than just radiation. That's never been definitively proven in a modern contemporary trial, but we do think that there might be something to that. And we sometimes have patients referred to neurosurgery for that reason. Oops. One of the things that can impact surgery and outcomes after surgery, which really wasn't known for a while, but has been a relatively recent discovery, is that rarely surgery can disperse tumor cells beyond the surgical cavity. So this is a case of a patient who had surgery, and the cavity is in green. As you can see, there's no real white bright material there. That cavity looks clean. But in red, you see these nodules that are clinging to the outer lining of the brain. And that's something that's called pachymeningeal seeding. Some people call it nodular meningeal disease. But the idea is that at the time of surgery, in a small percentage of patients, tumor cells escape the surgical area and they show up later, usually months later, but they're along the lining of the brain, no longer in the cavity. And in the past, we didn't see a ton of this because in the past, the standard of care was to give patients whole brain radiation after surgery. But now that we're doing less and less of that for reasons that we'll explore later on today, we're seeing some of this picture because we're no longer treating the entire brain with radiation routinely. We're being much more selective with radiation, but those little cells that were previously controlled in those small patients, small percentage of patients that had seeding, now there's nothing to control them. And we're seeing this phenomenon a little more. It's really, really, really important to distinguish this entity of surgical seeding or pachymeningeal seeding from true leptomeningeal disease. These are very, very different entities. They have a different cause, their natural history is different, the risks to the patient are different, their management is different, but it can be very nuanced and tricky. So a lot of times when we hear about a patient and there's a diagnosis of leptomeningeal disease, but we also know that they've had surgery, one of our first and foremost things to do is get the scans and look at them, because you can distinguish them based on imaging, but sometimes it's not always super clear, and sometimes people get sort of labeled with the wrong diagnosis. So this is a relatively new entity, and that explains part of it, but it's something that I think is really important for our field to address. There's many, many trials now trying to mitigate this phenomenon of pachymeningeal seeding. Most of them rely on one central idea, which is instead of giving radiation after a surgery's been done, give it before. And that way, if cells escape the operative area, they've already been radiated and they're less likely to form into actual tumors. That hasn't been established as the standard of care, but these are just the clinical trials evaluating this idea. And you can see there's many, many of these trials. So within a few years, hopefully sooner, we'll have a much better understanding if this is something that should be done routinely, as opposed to in unique circumstances or on a trial. So let's pivot to systemic therapy or drug therapy. So thankfully, there's many new drugs that are being developed in oncology. And what's even more exciting is many of those drugs have potential to work in the brain because they tend to be better and better at penetrating through the blood-brain barrier. In the world of non-small cell lung cancer, EGFR mutant patients who receive EGFR therapy, almost all of those drugs can work in the brain and often can work quite well. The same is true for ALK rearranged non-small cell lung cancer. And not only that, but there's just many other mutations that occur maybe less frequently sometimes, but have agents that can work in the brain. So non-small cell lung cancer has really been amazing as a field in terms of developing, targeted therapies based on a patient's specific mutational status and giving them drugs that help them everywhere, including in the brain. Even in patients who don't have a targetable mutation, and who have an adenocarcinoma, which is the most common type of non-small cell, a drug called pemetrexed can be effective in the brain, and then immunotherapy can be effective in the brain. But immunotherapy's greatest success may be in the world of melanoma, where it took what was generally considered the most aggressive, the hardest to control type of brain metastasis, and it's made it the one that you can actually cure a reasonable percentage of patients in. And it's been really transformative. And one of my clinic now has so many patients who have melanoma in the brain, but I really should say had melanoma in the brain because immunotherapies have just transformed their situation and led them on a very, very positive path towards permanent disease control. Not everybody gets that response, but more and more patients are getting those responses as the immunotherapies get better and better. In addition, melanoma has targeted therapy for patients who have certain mutations. For example, people who have a BRAF mutation can get BRAF/MEK therapy. And then in breast cancer, for example, there's many options for intracranial disease control. Some of the best options are for patients with HER2-positive breast cancer, where there's several drugs with very, very good efficacy in the brain. This is just a table that shows the prospective studies that have looked at intracranial control in EGFR mutant brain metastases with drug therapy alone. And, I won't spend a lot of time on this, but if you look at the CR and PR columns, this means complete response or partial response, which basically means did the tumor shrink or disappear after the drug was started. You see very, very high numbers, when it comes to brain control. Similarly for ALK, the new ALK agents are very good at impacting the brain in a positive way. This is ROS1 and lorlatinib, and this is just a small waterfall plot that shows the responses to this drug in the brain, where the bars going below show the magnitude of shrinkage in individual patients on this drug. So in the world of breast cancer, there's, like I was saying, in the HER2-positive space, there's multiple drugs that can be effective. Trastuzumab deruxtecan is one. This slide depicts another one called tucatinib, which is typically combined with trastuzumab and capecitabine, and which can have very good brain efficacy. And this was a trial that was published, about 5 years ago now, especially the brain outcomes about 5 years ago. And what was really remarkable about this trial, which was led by my good friend and colleague, Dr. Nancy Lin, in the brain domain, was that patients with active brain metastases were enrolled. Previously, you had seen a lot of studies that either didn't allow patients with brain metastases to enroll on them, or they had to be radiated first, or they had to be controlled for some period of time first before they could go on a new drug therapy. But this study, which was called HER2CLIMB, actually allowed active brain metastases to enroll. And that was a really remarkable study design. And thankfully, we're seeing more and more of that so that we can really better understand how well these drugs work in the brain, not in tumors that are already controlled by radiation or which aren't growing, but in active tumors. And I think that's really important. So this was a really remarkable study in that regard. This is just an example of a patient who got EGFR therapy. These are 3 MRIs in time. The top left shows a couple of brain metastases, and then EGFR therapy was started after that. And you can see that they shrunk on subsequent scans, first the top right, then the bottom left. You do have to monitor patients very closely, though. You can't just start therapy and not scan them anymore. This is a patient who unfortunately didn't get as close of monitoring as we would have liked. So this was a tumor that was in the frontal lobe on the right of this patient's brain. It shrunk with EGFR therapy, but soon after that it grew and it caused issues and problems. Eventually these were able to be addressed, but the patient became symptomatic for a while because of this. People are always very interested in immunotherapy. How well does immunotherapy work? And it is indeed getting better and better as the immune agents get better and better. Probably like I was saying, the best success story is melanoma, where a couple of trials, one really pivotal one being Checkmate 204, showed that with dual agent immune therapy, meaning the combination of ipilimumab plus nivolumab, the response rates, which included stable disease for over 6 months, were between 50 and 60% in a cohort of patients that did not have symptoms or require steroids. And that was really exciting, not because of the response rate of 57%, but because so many of these patients had durable responses. And that's one of the things about immunotherapy that's very exciting, is that if it works, it has the potential to work long-term. So that was a very pivotal study that really transformed the field. Immunotherapy and radiation can synergize together very, very well, in both a good and a not good way. The good is that it can lead to better tumor control than you otherwise might see. And it's sort of like 2 + 2 = 6. where 2 of radiation plus 2 of immunotherapy leads to a combined 6, because the therapies can work together fairly well in the brain. This is sort of a forest plot. Again, we looked at one before, but the magnitude of the down arrows or the down bars show how much shrinkage there is in a given patient. And this is if targeted radiation was given by itself on the bottom, and you can see some responses. This is if targeted radiation was given with ipilimumab, an older immunotherapy. And this is if targeted radiation was given with pembrolizumab, also known as Keytruda. And that's a little bit more a newer immunotherapy than ipilimumab anyway. And you can see that the magnitude of responses was greater. The flip side of doing targeted radiation with immune therapy is you run the risk of more necrosis. And we'll look at necrosis, but basically this means that the radiation carries a small risk of damaging the part of the brain that we're treating, but if you give immune therapy, it's a higher risk than that. So when you combine immune therapy with radiation, yes, you tend to get better control, in my opinion, but you also tend to run the risk of more necrosis or injury or inflammation to the part of the brain you treat. And this is just an example of radiation necrosis over time. And you can see that these 2 tumors in the top left were treated. They grew, but they didn't grow because of tumor growth. They grew because of radiation-related inflammation and injury. And this ultimately led to a resection, and pathology showed just radiation changes, not tumor. So let's talk about radiation. There's 2 main types of radiation that we use. There's something called stereotactic radiation, which is also called SRS or SRT. And this is targeted radiation to individual tumors. We're not radiating the whole brain, we're just radiating the tumor. And then there's whole brain radiation, where we are radiating the entire brain. So let's look at targeted radiation. So this is an example, just a cartoon that one of our visual arts students drew, actually, showing a patient, mock patient, being treated with radiation. So they're lying on a table. They're in a mask. That's what this yellow thing is. It just holds them in the right spot for radiation. It's not invasive. It just kind of holds them in the right spot. And this is a radiation gantry that moves around the patient and shoots in radiation to just hit the tumor. And it's a technically complex procedure. So this is a graphic of a brain. The brain is in green. The red are individual tumors. So you can imagine if you're trying to hit all these individual tumors at the same time and do it with very minimal margin, because we don't want a lot of margin because that means more brain being radiated. It's just it's a technically complex treatment. But thankfully, the technology has evolved amazingly well over the past 10 years. And, doing something like this is now a routine thing that we can, do readily. And do so with very tight margins and with very, very good accuracy. And what's even better is that year after year, the technology gets better and better. So it should be getting even more precise and less associated with side effects in years to come. When we do radiation, we create what's called a radiation plan, and you can basically see like a topographic map of radiation dose, so to speak, on the brain. So these are the targets that we're going after in this example. And you can see like a high dose radiation area, moderate dose, and lowest dose. And you can see in this particular case, the brain is not getting radiated in full. It's just the targets that we want to go after that are getting radiated, and the dose falls off pretty steeply. One of the best things we can do to maximize both tumor control and minimize side effects, and we'll look at both of those, but this slide shows the maximizing local control of tumors with radiation, is to radiate when tumors are small. Radiating when tumors are small is one of the most highest return on investment that we can really do when we use radiation, because the radiation works better and it has less side effects when we treat small tumors as opposed to large tumors. So this graph just shows, this is institutional data from our center, which just shows how the size of a tumor increases and what its control rate is. So the lower the lower the bar, the lower the curve, the better the control is with time. So red, which is the smallest tumor, has better control than orange, which is the largest tumor. And that doesn't mean that when you see a tumor, you radiate it immediately. It just means that if there aren't drug options for that particular patient's brain metastases, and you expect no changes in drug options for a little while, like if they're, let's say, responding really well in the brain, I'm sorry, outside the brain, but they're progressing in the brain, then that's the type of patient to think about radiation early on for. But if like they have small tumors and they just started a wonderfully effective drug like osimertinib, then there's usually not as much need to radiate those tumors because they're going to respond to drug therapy with a very high likelihood anyway. And even if they don't, you're going to be monitoring closely and you can quickly course correct. We do have some patients that have tumors that are harder to control with radiation. And we're always looking for ways to make radiation better. This is a clinical trial that is available at our institution where patients with historically harder to control brain tumors or who have tumors that have already grown through radiation receive targeted radiation, and half of those people receive a gadolinium-based nanoparticle designed to make the radiation more effective, and half the people receive just radiation by itself. And the nanoparticle is a gadolinium base, so basically it's MRI contrast linked to this nanoparticle, and the gadolinium contrast is integral because it leads the drug to exactly the right spot in the brain, meaning it only gets taken up where there's a tumor. It doesn't get taken up by the rest of the brain. So hopefully this can lead to a selective increase in radiation sensitivity in the tumor, but not the surrounding brain. But that's not been definitively established, and that's why it's on the study. Let's talk about necrosis. So necrosis, as a reminder, was injury to the brain caused by radiation. This is what necrosis looks like. So this is a tumor in the top left image. This patient declined surgery, so she was radiated, and this tumor responded. But as you can see over the rows, starting in the top left, working across each row from left to right, and those are the subsequent scans, she developed this sort of cloudy, fluffy enhancement, meaning contrast uptake, at the rim of the treated tumor. And this was not tumor growth, this was radiation change. It led to surgery, it led to a drug called Avastin, but this proved to be a really impactful toxicity for this patient, is this radiation necrosis. Like we said, one of the best things you can do to minimize the likelihood of radiation necrosis is to radiate when tumors are small. It makes all the difference in the world. So I think that treating small tumors really leads to a much, much lower rate of symptomatic radiation necrosis than does treating larger tumors. Distinguishing radiation necrosis from tumor growth is a tricky entity, and I don't think anybody can do it perfectly. Nobody can. There's just, based on imaging alone, there's just no way to be 100% sure. But there are some features on MRIs or other imaging modalities that can point us in the right direction. And we can use some other features about a patient's clinical case to make that distinction as well, based on how does it respond to steroids, or how does it respond when a new drug therapy is given, for example. And usually we can figure this out with a high degree of likelihood eventually, but we're never totally sure. So occasionally patients will have to go to the operating room to sort of, get a diagnosis, but also it's a therapeutic procedure. So surgery can be very effective against radiation necrosis. So the treatment of necrosis can be just observation initially. There's a drug called Boswellia that can be used. Steroids can be helpful. A drug called Avastin can be used. Hyperbaric oxygen can sometimes be helpful. And then surgery can be effective as well. So the last couple slides, let's just talk about whole brain radiation. So this is where we're no longer radiating individual tumors, we're radiating the entire brain, usually because there's a reasonable number of tumors present. Now, we're doing less and less whole brain radiation. The reason for that is that data tells us that, and these are randomized trials evaluating omission of whole brain radiation versus no omission of whole brain radiation from the management of patients. These trials tell us that for patients with up to 4 brain tumors, and potentially a little bit beyond that, that whole brain radiation, although it leads to lower likelihood of developing a new tumor in the brain, causes compromise of quality of life and cognitive function, and does not improve patient survival. So as a result, for patients with a limited number of tumors, we don't use whole brain radiation for the management of those patients. If we do need whole brain radiation for patients with larger numbers of tumors, there's a couple things we can do to make the long-term toxicities of memory problems be more mild. There's a drug called memantine, which was shown in a study led by Dr. Paul Brown, published about 12 years ago. And this study showed that memantine, which is given to patients with other cognitive problems, can be useful for minimizing the impact of radiation-related cognitive change. And this drug can be helpful, and we use it for all of our patients getting whole brain radiation. You can spare an area called the hippocampus from the radiation field. So the hippocampus is most integral for memory function, and by leaving it out of the radiation field, you can get relative preservation of cognitive function versus if it was in the radiation field. So what it looks like is that the hippocampus here in the middle panel, that area is colder when it comes to radiation dose than when the entire brain is treated via conventional whole brain radiation. And there was a single-arm phase 2 study that put hippocampal sparing whole brain on the map. And then there was a more confirmatory randomized trial where patients who needed whole brain radiation were randomized to conventional whole brain radiation with memantine versus hippocampal sparing whole brain radiation with memantine. And the hippocampal sparing arm had better cognitive function. Lastly, you could say, let's just do targeted radiation to more and more tumors. Don't even do whole brain radiation. And this is something that we've tested in one of our trials, which looked at patients with up to 20 brain metastases, and they were randomized to receive hippocampal sparing whole brain radiation versus stereotactic radiation. And this study completed accrual last year, and results will be presented at ASCO this year, as well as ASTRO this year. So the main medical oncology meeting, the main radiation oncology meeting. We hope to be able to present results there. Lastly, there are some patients who have small cell lung cancer, and small cell lung cancer patients have been excluded from all of these studies in the past. So all of the studies that show that you can omit whole brain radiation, they excluded patients with small cell lung cancer. And that's because patients with small cell lung cancer were thought to always need whole brain radiation when even one brain tumor popped up in the past. And there were a lot of reasons for this, centered on local control of small cell lung cancer, but also more concerningly, the risk of new metastases popping up in patients with small cell lung cancer, which was greater than in other tumors. We recently completed a trial, which was presented last year, where patients with small cell lung cancer and up to 10 brain metastases were treated in a single-arm study with stereotactic radiation. And what we found is that we didn't compromise some of these important endpoints with targeted radiation, meaning we didn't make their brain outcomes worse in terms of new, like overwhelming numbers of new brain tumors or brain imaging that got out of hand or out of control. We didn't sacrifice that. We were able to control the brain tumors effectively with targeted radiation. Some patients needed more targeted radiation. An occasional patient did need whole brain radiation down the road, not many, but some. But we were able to show that you can get away with targeted radiation in these cases. And now we feel that even in small cell lung cancer with a limited number of brain metastases, it is reasonable to offer targeted radiation for those patients. So in conclusion, brain metastases, as we saw, are very common. They can produce neurologic symptoms that often depend on the size and location of brain metastases that are present. Radiation is very common. It still forms the mainstay of treatment, and most patients will eventually get radiation in some way, shape, or form. But increasingly, drug therapy is playing a vital role in the management of patients with brain metastases. Treatment decisions tend to be individualized, although, like I said, we use the literature as best we can, and there's clearly a need for more data to guide the field. So I just wanted to thank you all for your attention. It's been a pleasure to speak in front of you, and I'm more than happy to answer any questions that are on people's minds.
Thank you so much, Dr. Aizer, for giving such an incredible overview of symptoms and treatment side effects. As Dr. Aizer just mentioned, we will now take some questions. If you have a question you would like to be asked, please type and submit it using the Q&A button in your Zoom control panel, and we will answer questions as time allows. All right, our first question that we have here is, when is it considered brain mets versus breast mets? Can you clarify the difference?
Yes, this comes up a lot, and it's a great question because I think some of our patients will say that they have like brain cancer, and that is true because any cancer that involves the brain is technically a brain cancer. But the way we think about it is that if a breast cancer spreads to the brain, it's still breast cancer. It just happens to now be in the brain, just like it's in the lung or the liver or wherever it might be, and it still needs to be managed as breast cancer. Um, we might be introducing therapies that are brain specific, on the radiation side, for example, but it's still breast cancer. So even if it spreads to the brain, it's still the cancer that it originated as, which is a key driver of how we manage it and how we think about it.
Great, thank you. Since screening is not required for some primary cancers, what symptoms should patients be aware of initially to then advocate for themselves to be tested?
That's a great question. So the symptoms can be sort of general in nature. That could include, headaches. A lot of people have headaches, so we're really kind of focused on headaches that are different than a patient's existing headaches. Maybe they're worse. Maybe they're in the morning when they wake up. Maybe they're more frequent. Maybe they're more severe. Maybe they're a different character. So sometimes that can be a presenting symptom. Nausea can sometimes be a presenting symptom, but nausea tends to be not as specific for the brain. Anything resembling a seizure, which is generally, we think of seizures as like loss of consciousness, and that is about a third of the seizures in the brain metastasis population, but about 2/3 of them tend to be more focal, where the patient's sort of not losing consciousness, but something is going on neurologically that they can't control. For example, spasming of an arm that lasts for a minute or two, funny visual lights that go away after a few minutes, difficulty with words, not like finding the right word to complete an individual sentence, but real inability to speak for a period of time. So anything resembling a seizure can indicate the presence of a brain tumor. And then there's focal symptoms, depending on the part of the brain that a tumor might involve. Weakness on one side of the body. It'd be unusual for someone to have right-sided but not left-sided weakness, if they were just sort of tired. So that could indicate something wrong. Numbness, tingling, or sensory problems on one side of the body could indicate a brain or a spinal cord problem. Difficulty with swallowing, difficulty with balance and coordination, new trouble with walking. Anything that when you think about it, I wonder if that's coming from the brain, is a good thing to bring up to your oncologist. And if you're unsure, then always err on the side of more disclosure, because sometimes symptoms that don't always feel like they're related to the brain sometimes could be related to the brain. So always good to mention.
Great, thank you so much. We have a question here. First and foremost, somebody commenting saying, thanks so much for a great talk. And this person is asking, would you briefly address treatment intent, palliative versus curative?
That's a fantastic question. And our goal is to make more and more treatment curative. And I would say that each year, more and more patients are cured of their brain metastases. And largely, that's due to improvements in drug therapy, specifically the immunotherapies, but sometimes other therapies. So we want cure for everybody. However, we recognize that it isn't always possible to cure everybody. And there are some patients where the likelihood of any sort of long-term disease control is unfortunately relatively small. And for those patients, our number one priority is to preserve their quality of life as well as quantity of life. And it's sort of an individual discussion with patients about what are your goals of treatment? What's important to you? What are you looking for? And sometimes patients have definitive answers. Sometimes they're not totally sure. But what we really strive to do is give patients as much time as we possibly can with as much quality as we possibly can. And that includes, preventing the tumor from causing problems, but also being very cognizant of the side effects that our treatment can sometimes impart. So it's sort of a balance. So hopefully more and more and more will, aim for curative approaches, but the majority of patients now with brain metastases still, the intent is for promoting quality, focusing on palliation, and preserving, every day, every minute, to be as best quality as possible.
Great, thank you. The next question that we have is if targeted therapy synergizes with RT like immunotherapy does.
That's an excellent question. I don't know if we have a definitive answer to that. There are some studies exploring that possibility. I think for the most part, and this is more my opinion than scientific fact, I think they're additive, meaning I think that targeted therapy can be very, very effective in controlling the brain of patients with brain metastases, as can radiation. But I don't know that it's a 2 + 2 = 6 situation. I think it's more of a 2 + 2 = 4 situation. That'd be my take on it. But I think one of the nice things about patients getting targeted therapy is that they tend to be very effective. So we often see like significant control for prolonged periods in those patients.
Great, thank you. Okay, we have a question here commenting on how you are so experienced and knowledgeable, and how can somebody find an experienced and knowledgeable radiologist like yourself and not just rely on a referral?
I think that's a good question. I think every center, is going to be a little bit different in terms of how they approach patients with brain metastases, and obviously there's a lot of factors to balance. We have some patients that come from far away to visit us, and other patients it's just not physically possible. One of the nice elements of telemedicine is that, especially with increasing state licensing that we're able to achieve, is that we now can interact with patients in many states through media like Zoom or even phone calls, and that can cross state lines more and more. So I think that's a real positive change of late. Hopefully we'll get to the point that it won't matter what state patients are in, but we're not obviously there yet, from a medical, legal, and just sort of institutional standpoint. I encourage patients to get second opinions, and that also is true for patients who visit our center. So we often, especially when patients are facing like a real dilemma in terms of how to approach their situation, we encourage them to go to another perspective. We're lucky that we have many wonderful institutions within our city, and it's really easy to send them to Beth Israel or to Mass General Hospital or to another center that we work closely with. But and sometimes that can be more challenging. But I think getting additional opinions can be very helpful. And I think the other thing to remember is that you're not always transferring your care. In fact, many patients are not transferring their care. They just want to have someone in their corner should the situation arise, where they need another perspective. So we'll meet patients already on a wonderful treatment plan that we fully agree with. But we're there so that if there is a progression in the future, now they have their local team and they have us to sort of work together and find sort of what treatment plan makes the most sense. So I think getting a second opinion can be really helpful, even if it's not all about getting your care at that center.
Great, thank you so much. And I just want to encourage patients to be their own best advocate. Next question that we have here is there a greater chance for someone to get brain mets if they already have a brain tumor along with a primary cancer?
Yes, so I think I'm assuming that means like a brain metastasis, and the likelihood of getting another brain metastasis. And I think there is a link there. If someone has like a meningioma or something like that, which is like a benign brain tumor, we wouldn't expect that they're more likely to get brain metastases because of that tumor. But I think, yes, when someone has at least one brain metastasis, then it's just much more likely that at some point they'll develop another one. Not everybody does, but I think no matter what cancer type they have, once they develop one brain metastasis, now all these screening goes out the window, because we are going to be routinely and dogmatically doing brain scans for them indefinitely. So So yes, although there is a little bit more likelihood now, we're often picking up metastases when they're small, when we can address them with much less intense therapies. So yes, that is a risk factor, but it often triggers more imaging that can mitigate the impact of that.
Great, thank you. Next question we have here is, what therapeutic options are available to help patients manage the cognitive effects of metastatic brain tumors and their treatments?
It's a great question. The cognitive element is really, really important. There are patients who don't even have brain metastases who have cognitive impairment, and people often talk about chemo brain, and it's really a real thing. Even if the brain has nothing wrong with it in terms of anything you can point to on a scan, our patients go through a lot when it comes to their cognition. And that's even more true if patients have brain tumors, need radiation, need other treatments for like surgery for management. So I often tell people to do a few things. One is I say to use the brain as if it were a muscle. And if it's sort of like use it or lose it. So I think just like if you don't use a muscle, you're going to get weak. If you don't do physical therapy, you're not going to rebuild strength. I think the brain, it's really important to use it. And that can mean many things to many people. That could be Sudoku, that could be reading a newspaper, learning the basics of a new language, whatever it is that keeps your mind stimulated, I think is important. Because I worry more about the patients who are not doing those things than the patients that are. The other thing I would say is that most larger hospitals have neurocognitive specialists. And I don't think a single day goes by where I don't offer a patient a referral to a neurocognitive specialist. And I don't think a lot of patients know that they exist, or we could do a better job making it known that they exist. But if a patient is having neurocognitive issues, referring them to a cognitive specialist can be really helpful. And they'll go through batteries of tests and give them kind of an individualized treatment plan for how to best preserve and maximize their cognition. And they're a really wonderful, wonderful resource. And most patients don't even know that they're out there. So just recognize that, you could ask for a referral, and it might mean, depending on the size of your hospital, going to a different center potentially, but for someone with neurocognitive expertise to help guide you specifically.
Great, thank you. The next question we have is, are scans, such as a CT scan or an MRI, enough when determining if somebody has a brain mets? Are there any other modalities for that?
I think for brain metastases, scans are sufficient, meaning there's nothing else beyond a scan that someone would need, CT or MRI. For leptomeningeal disease, which we touched on, there's a small subset of patients who you really don't see anything on the scan, but there could be little tumor cells floating around somewhere, and a spinal tap becomes part of the equation. So for intact brain metastases, scans really tell the whole story. And MRIs are so good in the brain nowadays that we pick up tumors that are 1 or 2 millimeters in size, and they're really amazing quality these days. Like tumors that you could never find anywhere else in the body, you can find in the brain because of how good the quality of the imaging is. But for leptomeningeal disease, sometimes you do need that spine.
Great, thank you so much. Well, that is all the time for questions that we have. We just want to say thank you so much, Dr. Aizer, for being with us today and for sharing your insight and expertise. A special thank you to each one of you, our attendees, for joining us for day 1 of our Brain Mets meeting.
It was a pleasure. Thank you all so much. Thank you for organizing, and just thank you to the entire ABTA for this entire week of wonderful talks, which I'm very much looking forward to.
Thank you so much, Dr. Aizer. We welcome you to join us back at the same time tomorrow at 1 p.m. Central Time for day 2, covering maximizing brain health, keeping your brain fit. You can join tomorrow by clicking the same link as you did today. If you were unable to get your question answered or want to keep the conversation going, join Dr. Aizer and our day 2 speaker, Dr. Piccioni, for a week-long Ask the Expert on ABTA's online support community. Scan the QR code to start sharing your questions now at abtainspire.com and get your questions answered Monday, April 14th through Friday, April 18th. Thank you to our Metastatic Brain Tumor Collaborative partners for their partnership and support in putting together this meeting. Additionally, thank you to ABTA sponsor Accuray for their support of this meeting. For more information about ABTA's programs, events, and services, connect with us on social media, Visit ABTA's website at abta.org or email us at info@abta.org or call our care line at 1-800-886-2282. This now concludes day one of our 3-day meeting. Thank you so much for joining us, and we hope to see you back tomorrow. And thank you again so much, Dr. Aizer. Take care, everybody, and we'll see you tomorrow.